local health service is at the very centre of any sort of community. I mean, I'm a receiver, on a selfish level, I'm a receiver of healthcare from this surgery. It's in my interest and my family's interest to make sure it is as good as it possibly can be. And I know the benefits it can be. And I've worked on the fringes of this service and elsewhere doing other things, and it's time to put something back.
This is our chance to have our say and to make it better, not just for ourselves, but for the whole patient community that we have here. And I think if we can do our little bit and give up our time to make things better, we're all going to benefit.
In Stoke-on-Trent, we've got 53 general practices at the moment. They're all different sizes, they're all different types. Before we had a real focus on this about a year ago, then about half of those general practices had patient participation groups that worked effectively. Now there's been a lot more focus on it over the last year or so, and as clinical commissioners we're really trying to push the need for this at the front line and through the locality groups and with the senior commissioning managers.
We actually have our own membership scheme, so we have 2,500 registered members who covers Staffordshire and Stoke-on-Trent who've expressed an interest in health. We're able to split these down by GP practice, so we're then able to contact the individuals and ask them if they'd like to get involved with their practice.
Because there are two elements to the work that we've been doing. There's the insight database which collates the information, and there's the model of involvement that then embeds that insight into making sure that patients are involved in decision making from practice level to board level. It hasn't been difficult to persuade patients that that's a good idea, and because of the demonstration of changes to services like podiatry and continence, it's not been difficult to show the value of patient input.
It's patients who receive the services that we as commissioners commission and that providers provide, and they are very well placed to give us feedback as to whether the service that they needed was there and the quality of that service that they received. So it's an important feedback loop in terms of commissioners.
So say you're going to set up a new mental health service, then maybe one locality group could take the lead on looking at what the service needs are, looking at the service that's helping with a service specification, and being there when they put it out to tender and they're looking at who's the most appropriate to win the tender. So I'd see those locality groups as doing some pretty hands-on frontline work, but also being able to do that more thoughtful commissioning that goes through the whole commissioning cycle. Previously, the clinical commissioning group were new to the job, weren't quite sure exactly what patient involvement was about, didn't necessarily know what they didn't know. So it was very much a collaboration, it was very much a coaching exercise to help them to understand the benefit of the information. As the information was aggregated and as the services could be demonstrated, it was easy to convince the GPs and the clinicians that it was the system to use, because they were able to clearly see exactly what patients were telling us and were able to use that to review services.
One of the problems that we face is that a lot of the information that we get from patients is anecdotal, and what we're trying to do is get a more complete picture of what the patient experience is of the services around North Staffordshire. By following this model that Stoke Clinical Commissioning Group has come into, we feel that we can give more power to the patient voice in what we're trying to achieve in terms of developing the services, providing the services and commissioning services.
The system came around really from my role in complaints. I was a complaints officer, and a complaint really is when things have gone wrong and that's too late to do anything with it really. What we want to try and capture is the soft intelligence and the experience at a much early stage to alert us to any potential problems and stop it getting to a complaint sooner rather than later. They can access the database system. Their password will alert me that their interest is podiatry, and it will bring up all the information relevant only to podiatry services, giving them a real-time snapshot of the experience we've received so far that year. In the past it would have been quite clumsy to get this information because it went to various different locations and was coded in different systems. So although complaints might have gone into one system, comments may have gone somewhere else.
It was taking the approach from the commercial world of having one customer record, having one piece of information, having all the information about that particular customer or that particular service, and aggregating it up so you could really understand and provide some insight into what patients were telling us.
What this model does is bring all that together. So from the PALS group, we might collate all the information that they collect. There are focus groups that we hold with patients. There are patient participation groups with practices, and it's bringing all that rich information together into one database. And then by analysing that database and triangulating it, and by which I mean, you know, checking that one person's view does correlate with some other people's views across the system, we've got kind of some rich patient experience evidence that that we can take out to providers, or we can use as commissioners to say that there is a service need here. We need to develop this and get on and do that.
When we're challenged, how well are you engaging with the public? We can tell a story which describes how at every practice level we have a patient group which feeds up to a locality, of which we have 5 in the patch, which ultimately will feed up to a senate of patient reps, will feed into board level, which will help us design our annual strategy to inform the commissioning cycle of what we need to commission for patients on an annual basis.
We decided to aggregate the information under the domains of patient experience that are used in the inpatient, outpatient and GP surveys, which are 5 domains, which are clean, comfortable place to be, access and waiting, safe, high quality care, better information, more choice, and building better relationships, so that on a local basis we could understand what patients were telling us, but more importantly we could triangulate that information against the information from the national surveys. Using the domains gave us the opportunity to look at the big picture, but also to focus in locally and use that information for commissioners to understand exactly what patients were telling us.
The system is designed in a way that the analysis has already been done for the commissioners. They will log in, and the dashboards will contain a range of graphs that they will agree with me beforehand, showing them real-time data in a way that's meaningful for them. The dashboard is tailor-made really for every commissioner and for every service that would need it.
One of the major service changes created was the adult hearing. The original national spec was looking at the age of 55 and above. But on the basis of patient feedback, patient events that we did, the service has been changed to 18 and above. And we're the only area in the West Midlands actually doing that. And that was all based on patient feedback.
I personally believe patients do want to be engaged, but they want to know how to be engaged, and they want to know that their voice is heard. It's all well and good saying, right, we want to listen, but then we do nothing. And I think the proof for us will be about delivering what the patient has said.
Firstly, have a specific contact within the practice so patients know who they're dealing with and that contact can hold all the information. I think secondly is to be aware of the time that's going to be needed, so make sure that you set time aside each month to organise the meeting, but also to look at the actions associated with that meeting. And I think finally have an open mind. I think there's been some really nice results where practices have been quite concerned about setting up a group, but once the group's been established and they've had that first meeting, they've seen what a positive event it can be.
The lessons we've learned are that patients want to be treated as people and treated in partnership with the clinical commissioners, want to feel that they have a value in working with clinical commissioners and are able to challenge on the same basis and level. We've learned that there isn't one way of doing things, there isn't one right way of doing things. We've employed a number of tactics and joined those together to make sure that patients are embedded from practice to board level in the decision-making processes, and we've adapted lots of technological solutions to meet the needs that we've identified locally.